and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shamagam. I don't think there's a rheumatologist in the world who doesn't love looking after patients with gout. The joy of finding crystals is surpassed only by how happy our patients are when we resolve their flare and help them gain control over their disease. Initiating and titrating uric acid lowering therapy is something we're all trained to do, but recently, low serum uric acid has been potentially linked to adverse outcomes, including Parkinson's disease, dementia, and early mortality. With the question being, how low can we go? And is there risk associated with low serum uric acid? The manuscript we're going to be discussing today is Associations between Low Serum Urate, Body Composition, and Mortality, which was published in Arthritis and Rheumatology. A link to the manuscript is in our show notes from today. I'm very pleased to welcome the first author of the manuscript, Dr. Joshua Baker, to talk about this work. Dr. Baker is an associate professor of medicine and epidemiology at the University of Pennsylvania and the Corporal Michael J. Crescenz Veterans Affairs Medical Center in Philadelphia. He is both a rheumatologist and a clinical epidemiologist, and he has built his career focused around body composition and metabolic health in the rheumatic diseases. Welcome to the show, Josh.
Thanks so much for having me. I'm a fan of the podcast.
So, Josh, I wondered if you could start by orienting us to the background regarding the association of serum uric acid and mortality. What was known about this topic before you did this analysis, and why did your team come together to conduct this research study?
Yeah, of course. Essentially, what we have known for a very long time is that obesity, and in particular metabolic obesity, is strongly associated with hyperuricemia and gout. And this is thought to be because high insulin levels in the context of obesity cause urate reabsorption in the kidney. So we expect that people with greater fat mass we expect them to have higher uric acid levels. But conversely, we may also expect that those that are very thin to have very low uric acid levels. And the reason that latter observation is important is that, as you said, some poor long-term outcomes, such as things like dementia and early mortality, have been linked to low uric acid levels. So we hypothesized that this association, namely between low uric acid and adverse outcomes, was because those with low uric acid were likely to be thin, and perhaps pathologically thin, with significant loss of muscle stemming from that pathologic weight loss. So in other words, is it really bad to have a low uric acid, or is it just a bad sign about your health to be very thin? And ultimately, that question is what inspired this study.
So, Josh, this study used data from the National Health and Nutrition Examination Survey, which is a large data set often lovingly referred to as NHANES. Just to be clear, this has nothing to do with the US underwear company that was tasked by the government to make face masks in March of 2020. Josh, do you mind giving us a refresher on the NHANES database, also funded by the US government? In particular, where does the data come from? How were you able to access the data in that data set? And can any researcher do that? Or did you have special access because of your VA connections?
I had no special connections. I did have smart collaborators and mentors that taught me how to take advantage of these data. However, the data are actually publicly available, which is kind of amazing if you think about it. So this is a nationally funded survey, as you said, and it aims to characterize the US population in terms of a number of different key health metrics. And, when I say survey, it sounds like it's just a simple questionnaire that is sent out, but in reality, it's actually a highly complex and active sampling of the population through asking questions, but also performing exams and other tests.
And the recruitment of patients to the study is complex, right? Because it pre-selects for certain groups. Can you briefly tell us about that issue? And specifically in regards to the population that you analyzed in this study, did you use the full NHANES data set, or did you further select for this particular study?
Yeah, it's a really important point. I think one of the strengths of NHANES is the purposeful sampling, which sort of means that the work is really a reflection of the US population. But there are lots of different years of the survey where different tests are done and questions asked, and that creates different groups of participants. So often you're using a subpopulation within the larger survey. And there are different survey weights that are used depending on the groups that are being studied. So for our study, we used data from an 8-year period where whole body DEXA was performed on the participants. So using these data requires applying the correct survey weights specific to that group of participants. And then theoretically, the subgroup, if weighted appropriately, should still reflect the overall population. But like any observational study, there's always a risk of selection bias when you're choosing a subpopulation.
Yeah, got it. And in your study, you looked at serum uric acid level, obviously, as well as body composition assessments based on measurements taken during DEXA scanning. So I think we all know DEXA scanning for bone density measurement, but could you help us understand the DEXA body composition data that was evaluated and how sarcopenia was assessed?
Absolutely. Yeah, whole body DEXA is a really interesting technology or tool that's been around for a while, using the X-ray attenuation properties of muscle and fat to allow you to quantify muscle and fat content using X-ray. So we used the data from the cohort of patients from this study that had whole body DEXA performed, and we linked it to the other data from the study, like including uric acid levels and the mortality data. The DEXA data gives you things like muscle mass, fat mass, and it's imputed for people that did not undergo the testing. And then we converted the measures to Z-scores. So people are used to thinking about Z-scores and T-scores for bone density. A Z-score really just represents the number of standard deviations an individual is from the average within a category. So we used that data to look at these associations. And we also used a method that we created actually that adjusts for fat. So we have a measure of muscle mass that's sort of fat adjusted. And that allows us to look at whether uric acid levels are associated with muscle mass independent of the effect of fat, since we know that excess adiposity can also promote hyperuricemia.
Yeah, good. So tell us what you found.
Well, we found that those with very low uric acid levels were more likely to be underweight, to have lost a lot of weight, and to have low muscle mass, even after you consider their level of adiposity. So then we explored whether these considerations might explain why people with low uric acid levels are also seen to have early mortality. And we found that it did explain some of that risk.
And so what this data is telling us then is that when we see patients with low uric acid, perhaps we should evaluate more holistically other causes of pathologic weight loss that might be associated with mortality. But is the interpretation that more studies are needed to evaluate the relationships between low uric acid level and dementia and these other adverse outcomes that have been postulated in the literature?
Yeah, I think that's right. We felt that this study sort of gave a plausible alternative explanation for why low uric acid levels seem to portend adverse outcomes. But so, we're thinking that low uric acid levels are not really bad for you per se, but they identify a group of people that have suffered from pathologic weight loss and sarcopenia, perhaps related to aging or illness. And the relevance is really that any concern about the risks of hypoglycemia might make providers less inclined to treat gout aggressively, which of course isn't great for our patients. So I really agree with you entirely that we need more studies looking at things like dementia and other neurologic outcomes, because in that context, there seems to be a much stronger association between uric acid and those outcomes. And we did look at those outcomes in the study, but the power is pretty low. So it's a difficult thing to study, but I think important.
Yeah. So probably we can somewhat rest assured, though, from this data that it's not aggressively lowering uric acid level with therapy that's harmful. Am I interpreting that correctly?
I'd like to believe that that's the case, that we can say a little bit more confident after this that we can lower uric acid aggressively and not do harm to our patients. And I think that's a really important thing to be able to say. Any observational study obviously is limited, but this is a difficult thing to study with clinical trial data. So I think it's one step closer to being able to reassure us that we can treat aggressively and not be doing harm to our patients.
Good. That's a relief. So I have one other question, and this is going to have you speculate a little bit. And, I'm not a gadget person, but I noticed that you mentioned in the discussion of your manuscript that some groups are using these body composition DEXA measurements and using them to correlate with biometric impedance data, which is often looked at and used in those smart scales that some of us may have in our homes and some of our patients may have in their homes that kind of give you your percentage body fat measurement. And mine tells me the weight of my bones. And I'm always a little disappointed that the weight of my bones seems to be so low, and yet the weight of my body seems to be significantly higher. I'm wondering if you could perhaps look into the future a little bit and speculate. Is it feasible that we might one day see a world in which smart scales in our patients' homes could potentially give them information about their uric acid levels?
Yeah, I mean, I think that's really fascinating. You get a lot of information just by measuring your weight, and it can tell you a lot about your level of adiposity as well. So weight is by itself quite correlated with uric acid levels. But I do think that things like bioimpedance, but also taking a waist circumference and other sort of measures you could potentially do at home could do a reasonably good job at predicting what your uric acid level is, at least over the long term. So it might give you a sense at home what your risk of gout is for sure. Uric acids aren't hard to measure, so it's easy to measure, but also some of the metabolic features are probably equally important. So is your cholesterol abnormal? Is your blood pressure abnormal? Some of those things that can give you some sense of whether the obesity present is really metabolically important. And I think that's what really drives the uric acid levels. So I think you can get part of the way there and get a good guess, but maybe not highly accurate, if that makes sense.
Yeah. And of course, we all know that a lot of the issues in regards to gout flares is really flux of the uric acid level, right? So an individual measurement doesn't necessarily matter as much as the kind of acuity of change of the uric acid level. And I definitely think there'd be a need for some level of interpretation of that for patients, particularly maybe incorporating some understanding of if the uric acid level is low or stable. That means they should keep taking their medication, or maybe you do some kind of pairing with texting that gives them encouragement to say the medication is working, keep at it. And then, of course, this question of when can you safely cheat and how do you decide whether that's a good idea or a bad idea? I guess those things are all things to be considered as we give patients their data in their own homes, right?
Yeah, I think so. I think once you start treating someone too, it's hard to predict what their uric acid is going to be because you don't know how they're going to respond to the therapy exactly. So I wouldn't reassure anyone that the risk of gout based on their body composition, but I think it can be informative.
Yeah. Yeah, no, and I feel like probably the safest thing my smart scales actually do every day is just tell me what the weather's going to be and whether or not it's going to rain today. So I wondered if we could change tack now a little bit and talk a little bit about your career pathway. Could you tell us how you got your start in clinical epidemiology research? And particularly, how did you find your niche in this focus on body habitus and sarcopenia?
Yeah, of course. I published my first paper in medical school, and I think I just became an addict. I really enjoyed the sort of creative aspect of doing research and writing. And I just decided I wanted to have that be part of my career. So during my fellowship at Penn, I did a formal training and got a master's degree in clinical epidemiology, which I think really helped solidify my interest, but also give me some of the tools that I needed to sort of see what a career would be like. I think I owe the interest in body composition to my mentor during that program, who was Mary Leonard, who got me thinking about not only body composition and its impact on health outcomes, but also sort of what are the methods that exist to try and sort of capture that, which is complicated and interesting to think about how to take meaning out of those tests and those assessments. So the more I learn about the topic, I realize that it's increasingly difficult to really capture what we're really trying to get at, which is sort of the metabolic changes that can occur with aging and chronic illness. And I think body composition is sort of just one piece of that interest.
And you've obviously been incredibly successful obtaining funding through both the VA and other mechanisms, and you have a VA Merit Award. Do you have any advice for faculty just starting out in VA roles about how to get involved in research at the VA?
Yeah, sure. I think the VA can be a really nurturing environment for young investigators. So there is a really excellent career development program, particularly if your personal or research interests align with those of the VA. And the other thing about the VA that's really great is that we have all these existing networks among rheumatologists and researchers with all sorts of different interests. So there's like several different research registries and gout, RA, and spondyloarthritis. So getting involved in one of those networks can really help you create collaborations and mentorship that I think aren't just important, but maybe necessary at this point for real success. I've been lucky enough to work with the VA Rheumatoid Arthritis Registry. I don't really think I can overstate how important that has been for me in my career. So I think having the opportunities to establish collaborations within those networks can be really valuable.
Yeah, as I look at other institutions around the country, it seems like a really fertile ground for growing and nurturing junior researchers. And I think it's really interesting to sort of hear how people build their research interest. And so you have this interest in body composition, but you've also built this kind of body of work in the field of sarcopenia and rheumatic diseases and how that interconnects. Do you have any tips for people either as junior faculty or maybe senior fellows thinking about trying to find their niche and how to grow their own networks?
Yeah, sure. I think my interest really stemmed from just observation and seeing that the topics of sarcopenia and body composition seemed important, but were really under-discussed. I think that's that observation, I think, merits further study. So I think from my view, I think that my area might seem a bit niche, but it also at the time seemed very relevant over like a broad range of conditions. And then I sort of saw how it could be really relevant to our patients with rheumatic disease, where things like physical function are really important as an outcome. So I think the advice I can give is sort of don't overthink it maybe. And I know that might not be great advice, but to really, if you see an area that is exciting to you and is sort of under discussed, that it's probably worth exploring if it's exciting to you, but don't worry about moving on if it doesn't continue to spark joy.
Yeah, I think that's really good advice, right? As sort of trust your instincts, really, is what you're saying. If you're seeing something that's interesting to you, it's probably interesting to other people, right? And also important to our patients. I feel like that's one of the most important things as an early career investigator.
Yeah, I think the biggest thing is really finding something that's exciting for you. And then the second step is trying to create that strategic plan for yourself with a mentor and with something like a career development grant where you can really sit down and think about how to build a program around that interest. And that's where you need good mentorship and a good team to help you sort of figure out how your interest fit into sort of the landscape of the field.
Yeah. And then I think one of the things that was very helpful to me actually was realizing that I had to learn a different skill set than the skill set that my fellowship alone had taught me, and that there was a need to keep that kind of continuous learning and developing those skills as my research program grew. And I think some of those are pre-made as career development programs, but some of those are built organically around the particular area of interest that you're studying, right? Your epidemiology interest kind of grew alongside your research interest, right? Or had you done your epidemiology training before your rheumatology training?
No, I think that's exactly right. I did my master's degree as part of my fellowship. And I think that's such an effective way to approach it because it allows you to think about the research questions while you're sort of absorbing you're getting all this like new clinical information that's sort of cutting edge, I guess, in your fellowship. You're sort of able to sort of see how your new skills could be applied. So I think that's a really effective way to approach that. But I also agree with you that it's sort of a long-term process of absorbing new information, new clinical information, and understanding what the clinical world is like, and then trying to see what methods you need to sort of explore new questions. So it's sort of a long-term learning process as well.
Yeah. And I think that's one of the things as a junior career investigator is important to have enough ability to see within yourself of areas where I would benefit from additional training, or I think this course would be really helpful to me as I grow my career in a different direction. I feel like that's something that sometimes early in your career you don't necessarily realize is important, right? You think, oh, I've graduated fellowship, I'm finally done with training. I don't need to do any more courses that are going to give me busy work or homework or whatever. But actually those things still are really important because you are still learning and you're kind of learning throughout your career, right?
Yeah, I agree entirely.
So, Josh, it's really been a pleasure having you on the show today. I do want to point out that we have managed to have an entire podcast about uric acid without causing any flares. And I want to close this episode just by thanking the patients who participated in the NHANES study. I think it's an incredibly forward-looking study that was set up many years ago by the US government. It continues to be funded. And these large longitudinal databases really help us understand health and disease over time and provide answers to questions that could never have been conceived of by a single investigator or a single research institution. So thank you to all those patients who participate in NHANES, and thank you also for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.